All right, good morning, everybody. Welcome back. Hopefully you had a good night's sleep, ready for a nice full day of learning. All right, so I'm gonna get us started today. I got to talk to you guys about parking yesterday, which was really exciting, and now I get the 8 a.m. intros and the 5 p.m. panel, so you guys are gonna hate me by the end of the weekend. So a couple things, just a few things to review before I talk about our great speaker this morning. New Wi-Fi password. I know the Wi-Fi was a topic of conversation yesterday. So the Wi-Fi for the meeting room is Hyatt Meeting. The new password is Hyatt Encore 24, capital H, capital E. Yeah, question. Oh, okay. I'll tell him. I think it worked for mine. Oh, yeah. Oh, I don't know. Yeah. Supposed to be new. That's what I was told. If you have any issues, come find us. We'll try to figure it out for you. Just a quick schedule review. So obviously you guys are here now, so you made it to the right spot. This morning is going to be all didactic stuff and some live on screen. So an exciting morning. We got some great speakers lined up for you guys. I think it's going to be fun. And then we'll break for lunch after that. For those of you that signed up for the optional yoga, it's a good choice. You guys will get all loosened up after sitting for a couple hours. Lunch is on your own, so make sure you guys find a nice place to eat, get some good lunch, get prepped for the afternoon. When we come back in the afternoon, you guys will be going into your breakout sessions or coming back into here. If you're on the wait list for one of the breakouts, make sure you come into here. Don't go line up at the door waiting, hoping, right? Knocking on the door like, is it ready yet? If you do get off the wait list and into the breakout, you'll get a notification through the app and through your email. So you can just be in here. You can always move down there. We've got some great speakers after lunch in here as well. So worst case scenario, you could see something great in here. And then locations of the rooms, again, you're going 2 floors down, right? So you go down the escalator, take a right, go down the stairs, or go straight and go down the elevator. And all the rooms are in the Pacific rooms. And then bathrooms, if you guys need to take a break, head out through this back door right here, take a right. There's bathrooms right there. There's also bathrooms kind of further down as well. And then want to thank our exhibitors again. Make sure you guys go and talk to them. There's some great stuff out there. You guys can all go test your grip strength and see how strong you are. Challenge each other. All the PTs in the room already probably did. But all the MDs, you guys can all challenge yourselves. There's some great stuff. Go learn, go listen, get some free stuff. It's fun. And then the last thing is I just wanted to thank you guys for being here. We're excited to have you, and I think it's going to be an exciting day of learning. So sit back, relax, and I'm going to introduce our first lecturer. You guys already have met our first lecturer. I'm going to welcome back Dr. Elly LaRoque. Elly is one of the co-chairs of this conference. She's a professor at UCSF Sports Medicine and the medical director of the UCSF Redwood Shores Orthopaedic Clinic. Dr. LaRoque is also a founding member of the UCSF Women's Sports Medicine Center, our new group over there that's doing some great stuff. She's a team physician for Sarah High School and the Academy of Art in San Francisco. She's the perfect person to speak with you about top shoulder problems and demonstration of a complete and succinct shoulder exam. So, help me in welcoming Dr. Elly LaRoque.
Great, thanks so much, Danny. And good morning, everybody. All right, so today I'm going to be covering about 5 different shoulder topics that come up very frequently in primary care and also physical therapy and athletic training. This is my disclosure slide, consultant for Moxamed, but that's not relevant to this talk today. Okay, so some of the topics we're going to be covering are impingement and rotator cuff disease, adhesive capsulitis, also labrum tears and specifically a slap tear, and also we'll touch on shoulder arthritis. So we'll just jump into this first case. This is a 50-year-old right-hand dominant woman with type 2 diabetes, presents with 3 months of severe left shoulder pain. There was no injury. She's waking up at night due to pain. Her shoulder feels very stiff. She's having trouble reaching behind and also raising her arm above her head. On exams, she has no muscle atrophy, no point tenderness. There's decreased active and passive range of motion in all planes. Her rotator cuff strength is good. It's 5 out of 5, though it's difficult for her to perform some of these strength tests due to pain and limited range of motion. And you also have a shoulder x-ray of the affected side, which is normal, no arthritis. So this is a key finding in this diagnosis if you look at this patient. So look at the left shoulder. She has very restricted external rotation. So these are some different options to treat the patient. You can think about a sling for comfort, a steroid injection, physical therapy, obtaining an MRI, or referring her to one of us for arthroscopy. But really with this limited external rotation, limited passive and active motion, and a normal x-ray, I'm definitely thinking about frozen shoulder. So I would actually say that there are 2 options on this slide which are reasonable. One is you could consider sending them to physical therapy, but with frozen shoulder, often it is just so painful that it would actually be better for them to have potentially a cortisone injection first. So I would actually consider shoulder cortisone injection first. And so again, range of motion is key in this condition. So active range of motion is decreased, passive range of motion is decreased. The x-ray, if it's abnormal and has arthritis, then you consider the stiffness and pain to be shoulder arthritis related. But if the x-ray is normal, then generally you'd want to think about frozen shoulder. And for these patients, if you order an injection, ideally you want the injection done under ultrasound guidance, and you want it done in the glenohumeral joint. Studies show a subacromial injection can help some, but generally a glenohumeral joint injection would help more. So usually for these cases, I would actually have one of my primary care sports medicine partners, like Dr. Hadamiya, who's in the back and is your next speaker, perform the injection for this patient. So often adhesive capsulitis is really just a clinical diagnosis with, say, a normal x-ray. It affects women more than men. It's about 5 times more common in patients with diabetes. It's also more common in patients with thyroid issues and also who are positive for HLA-B27. The most common age group for this diagnosis is 40 to 60. There's actually no need to get an MRI for adhesive capsulitis. Associated rotator cuff tears are very rare with adhesive capsulitis. In fact, there was a study that was done that showed it was even less than 1% incidence of, say, significant rotator cuff tears in patients with adhesive capsulitis. So you definitely would want to get x-rays to differentiate between adhesive capsulitis and glenohumeral arthritis. And this was interesting in a more recent literature search. There was a higher percentage of shoulder visits for adhesive capsulitis during and after the COVID-19 pandemic compared to prior. And they think some of that might be due to SIRVA cases, but also during the pandemic, people were less active and maybe not having as many shoulder dislocations and other diagnoses like that. So just the general percentage of patients presenting with frozen shoulder was a lot higher. So there are 3 stages of adhesive capsulitis. Initially, it's the freezing stage. That's usually about 3 to 9 months. That stage can be extremely painful. They start to have limited range of motion. They often also have difficulty sleeping. And then the frozen stage is generally about 4 to 12 months. In this phase, they often have less pain. It's fairly stable, but they definitely are very stuck. They have limited range of motion. And then patients usually eventually get to the thawing phase. It can be about 12 to 42 months out though. And thawing phase is associated with gradually less pain and increased range of motion. So resolution for frozen shoulder is usually anywhere from 1 to 3 years. It can be very frustrating. And there was one study that showed without treatment, on average, frozen shoulder takes about 1.6 years to fully resolve. So what is the pathology of frozen shoulder? It's really thickening of the joint lining and capsule with inflammatory cells and fibrosis. So for treatment, you do want to optimize diabetic control. Pain control, you can offer anti-inflammatories, also injected steroids, as we talked about, ideally ultrasound-guided glenohumeral injections. And I believe these interventions do help with pain control and sleep. And you can also add physical therapy. I think that that does help restore some range of motion. You can consider acupuncture. There was actually an article I read suggesting that bee venom acupuncture might be helpful. So I'd say acupuncture could be helpful with adhesive capsulitis. There are also capsular distension injections, also called hydrodilation, that our primary care sports medicine partners perform at UCSF that can be helpful. And also suprascapular nerve blocks, which our group also performs, which can really help the pain for a few months and overall help patients with frozen shoulder with their symptoms and progression. So just to kind of drive home how significant the connection is between diabetes and adhesive capsulitis. So the incidence of adhesive capsulitis in this diabetic cohort was 3 times that of the comparison cohort in Taiwan in this study. And there's also a cumulative effect of elevated hemoglobin A1C. So that is significant for each unit of time that the hemoglobin A1C level was greater than 7. There was about a 3% increase in the risk of adhesive capsulitis. So you definitely want to make sure these patients have good diabetic control. So manipulation and surgery for adhesive capsulitis is very rare. This is a picture from one of my shoulder patients. Usually we don't even think about surgery or manipulation until they're at least 6 to 12 months out. And the shoulder usually is not supposed to have anything red in it. But in this shoulder, you can see that there's definitely a lot of redness around the biceps, around the humeral head. So it's a very angry, very painful shoulder. Okay, and a little bit about corticosteroids, because we were just talking about this with frozen shoulder. They do sometimes get a bad rap. Patients sometimes are anxious about them, but when I really think it's indicated, I just explain to them, look, it's just a very targeted anti-inflammatory. And the mechanism is that they do probably inhibit COX-2 and phospholipase A2, which are both inflammatory mediators. And as a perk, you can also use these cortisone and local anesthetic shots for diagnosis. So for example, there are a lot of patients that have concomitant neck and shoulder problems. And if you do a shoulder injection, you know where you injected it, and they get good pain relief. It helps differentiate what shoulder compartment is painful and also say shoulder versus neck. Okay, so here's another case. This is a 57-year-old right-hand dominant man who presents with right shoulder pain that started after he slipped and fell 3 months ago. Pain is in the lateral shoulder, deep to the deltoid. He tried physical therapy already without benefit, and it's waking him up at night due to pain. On exam, the shoulder is non-tender. His active range of motion is intact, but he does have pain on abduction between 60 and 120 degrees, so we call that a painful arc. He also does have some weakness with rotator cuff testing, about 4 out of 5. His shoulder x-rays are normal. So different options to treat this patient. You could consider a sling, consider a shoulder injection, recommend just continuing physical therapy. You could obtain an MRI or refer the patient to a surgeon. So in this case, I would definitely think about obtaining an MRI, or you could refer him to one of us first, and then we would probably get an MRI. So here's some key points in this history. So he's young, I would say. Now that I'm 50, I would say 57 is young. So this is a young patient. He slipped and fell 3 months ago. So this was a traumatic injury. And he has lateral shoulder pain deep to the deltoid. Often that correlates with rotator cuff pain. And he's already tried physical therapy. And he has active range of motion, which is intact, but painful arc. And he also does have weakness on rotator cuff strength testing, which usually you don't want in somebody who's 57 after an acute injury. And his x-rays are normal. So this patient has normal active and passive range of motion, but weakness and pain despite physical therapy. So again, review. This is a review for glenohumeral arthritis and frozen shoulder. This patient's different, right? They have good range of motion. So good active, good passive range of motion. So then you want to think about some of these other diagnoses. And in this patient, I'm worried about an acute, even full thickness traumatic rotator cuff tear that is now not improving with time and physical therapy. So we'll get into rotator cuff disease. It is very common. The prevalence of shoulder pain in the general population is about 14 to 34%. And of patients with shoulder pain, rotator cuff disease is the cause, we think, in about 65%. So rotator cuff disease is very broad. It encompasses impingement, also tendonitis, tendinopathy, which I also sometimes call bursitis. I tend to lump impingement, tendonitis, tendinosis, tendinopathy, and bursitis all together, and that's what I tell my patients so they don't get confused. You can also have partial thickness rotator cuff tearing, which we'll address, and full thickness rotator cuff tearing. So let's see if the pointer works. Yes. So full thickness tear means that there is a full tear within the tendon or it is completely detached off the bone. And a partial thickness tear means that the tendon is just partially torn or worn through. So general treatment for these different conditions, this impingement, tendonitis, tendinopathy, you want to try to treat those patients conservatively. So physical therapy, injection, and medication. Often for these patients, a subacromial injection is good. For a traumatic or symptomatic full thickness tear, like what I think this patient has, you do want to consider an MRI or orthopedics referral. And symptomatic partial tear, so whether it's traumatic or atraumatic, usually with these partial tears, you do want to try conservative treatment first. So consider an injection, physical therapy, and then if they are not improving, consider orthopedic referral and surgery. So this is some newer information about rotator cuff disease having both genetic and environmental factors. So the Journal of Shoulder and Elbow Surgery in 2020, in a genome-wide association study, identified 3 novel loci associated with rotator cuff tearing in upregulation or downregulation. And I have to say it's really interesting because I've been in practice now since 2007 and I've treated rotator cuff patients the whole time. And I've definitely noticed that often patients will have even atraumatic, symptomatic cuff tears on one side, and then say 5 years later, get it on the other side. Or if you ask them, they say, oh, my sister's had this, my mom had this. So I really do think that they can tend to run in families maybe because of these genetic factors. And then there was another study in JSAS from 2022, and this study identified advancing age, male gender, and higher BMI, so some metabolic factors being risk factors for degenerative, symptomatic, atraumatic rotator cuff tears. Okay, and a little bit more about the symptoms with this continuum of different rotator cuff, or with the different rotator cuff pathology. So for impingement, usually people have just pain at night, overhead activity, reaching, but they rarely have a lot of weakness. A partial rotator cuff tear, I have to say it is very variable in terms of how symptomatic they are and how they present. So pain is variable, but usually these patients do not have severe weakness. For full thickness tears, usually these patients have more consistent pain, more severe pain, pain at night, pain with overhead activity, and they also have weakness if they have a larger tear, and as these full thickness tears progress, the patients tend to get more progressive weakness. So why does all this matter? Well, recent data suggests that full thickness tears do tend to get bigger over time. Patients with full thickness tears improve more with surgery when compared to physical therapy, and we'll touch on that with some data. And surgery is not as successful with large tears compared to smaller tears, and also not as successful with muscle atrophy and with advanced age. So this study by Jane looked at operative versus non-operative treatment for rotator cuff tears short term. So their longest term follow-up was only 1.5 years, and they overall found that for younger and high demand patients, especially if they were not happy after physical therapy, that these patients get better outcomes short term with surgical fixation. And then this study by Moosmare looked at 10-year follow-up, so longer term, of physical therapy versus surgery for small to medium full thickness rotator cuff tears. And they found that for younger high demand patients, especially not happy after physical therapy, that these patients had better outcomes long term with surgical fixation. So there is some rationale for early surgical treatment of symptomatic rotator cuff tears, especially full thickness tears in younger, more active patients, and of course if they have failed physical therapy. So smaller tears do better with surgery. They have better muscle quality, better healing rates, lower rate of re-rupture, easier rehab, and also overall better short and long-term outcomes, at least in some patients. So what about partial thickness tears? So a lot of times patients will ask, because again, as I said, it's so variable in terms of presentation and clinical progress. Will I get better? I usually say, yes, you can, and only about 30% will progress over the next 5 years. Do I need surgery? Well, usually not at this time unless their symptoms are severe. We rarely should be operating on partial tears and impingement, so definitely we want you to go to physical therapy, but come back if your symptoms increase. So there are some recent studies to show if you're trying to manage a partial tear conservatively, that if all of a sudden it is rapidly progressing, say, into a full thickness tear, that usually people do have associated increased symptoms of pain and weakness as that progression is occurring. So will I do damage to my shoulder if I use it more? Generally, no, you won't, but it might hurt a little bit more and you can go play pickleball. Okay, so I always do tell my patients when I'm sending them to physical therapy for, say, tendonitis, bursitis, impingement, that I really do believe it works, okay? And I always try to explain to them why, even say with the shoulder model. So shoulder impingement syndrome, one reason is we believe that there's just less clearance in the area where the rotator cuff runs in between the humeral head and the acromion, and that this can create friction and inflammation. So with physical therapy, by strengthening the lower rotator cuff muscles, the internal and external rotators, those actually help bring the humeral head inferiorly. And then by helping with posture and their shoulder blade mechanics, that can actually help bring the shoulder blade back and down, which then elevates the acromion. So you are truly biomechanically creating more space for them. And there is data to show that physical therapy works well for impingement tendonitis, and that actually in-person and some hands-on physical therapy works better than just remote video visit therapy. Okay, and then just to throw a curveball in here, so I keep hammering, oh, if somebody has a symptomatic full thickness tear, you should send them to us, right? They will do better with surgery, but there is a high incidence of even asymptomatic incidental finding full thickness tears in the general population, but more common in certain age groups. So if you look at this data, there are asymptomatic full thickness tears that increase with age, so fairly low if you're only 50 to 59, it's about 13%. But if you look at patients over 80, greater than 51% can have an incidental finding full thickness tear on an MRI or ultrasound. So MRI in certain patients may show a full thickness tear, but just don't always assume that that is what's causing their pain. So main goals for referral triage to say the sports medicine physician should be to identify patients who have rotator cuff disease, and of those, identify patients who have rotator cuff tears, and refer, especially in cases where somebody had an acute injury and weakness and an acute full thickness tear. If somebody had acute change in their clinical course, so say you know that they have a partial thickness tear and all of a sudden their symptoms drastically increase, and also failure of conservative treatment, even with a partial thickness tear. If they tried physical therapy medications, maybe an injection, and they're still not improving, please refer them to us or another physician. And also, as we talked about, MRI can be very useful to guide surgery and to just see the muscle quality, see how large the tear is, and then that can help us predict the surgical outcomes for repair. So are there benefits of subacromial injections in rotator cuff disease? Okay, we talked about it with frozen shoulder. So there may be at least a small benefit for a subacromial injection for rotator cuff disease over placebo at 4 weeks. But I would say it is very variable. You know, I do these usually once for patients, and it's kind of all over the map how much pain relief somebody gets and for how long. I describe it to them as it's just like throwing a bucket of water on the fire. It is difficult to pull the data. There's variations in how these patients are diagnosed, different types of cortisone and injection medications, different locations, especially if you don't use ultrasound, you can't be 100% sure that you're really in the subacromial space. And there really are a lack of randomized controlled trials. But I think still doing one injection for tendonitis for a patient is totally fine, and we'll talk about why. So what are the risks of, say, a cortisone injection for people with rotator cuff disease? Well, patients with greater than or equal to 4 steroid injections had worse outcomes after surgery for large to massive rotator cuff tears. So we do think if you're doing many injections, say 3+, that can affect biologically the rotator cuff healing if they ultimately have surgery. So these days we don't recommend that many injections. Patients with 2 or more subacromial injections in the year prior to surgery for rotator cuff repair were more likely to have revision surgery. So again, if they're having multiple injections close to rotator cuff repair surgery, that could adversely affect the healing. And then these days we also have to think about infection. I know Dr. Edwards mentioned this yesterday. So there was a slightly higher infection rate with rotator cuff repair surgery in patients who had a shoulder cortisone injection within 1 month of shoulder surgery. So what do? I usually now limit my patients to 2 per year or 2 subacromial injections total if somebody is healthy enough and active enough to where they want to consider rotator cuff repair surgery if they're not improving someday. And then I also tell my patients you cannot have a shoulder injection within 1 month of rotator cuff repair surgery. Okay, so switching gears, this is another case and a different shoulder topic. So case number 3, this is a 30-year-old right-hand dominant man who fell off his bike 3 months ago, injured his right shoulder. He does not believe that it dislocated, but he can't get back to the climbing gym. He has anterior shoulder pain. He also has some clicking. He only feels pain if he moves the shoulder in certain directions quickly, and it does not wake him up from sleep at night. Physical exam shows no atrophy, no bony deformity of the clavicle or the AC joint, but he is tender over the biceps tendon, non-tender over the AC joint. His active range of motion of the shoulder is intact, but he does have a little bit of pain with full overhead activity. He has no weakness on rotator cuff exam, and he has a positive O'Brien's test. So treatment options here could involve shoulder sling, steroid injection, physical therapy, or MRI. And in this case, just based on his history, I do suspect an acute labrum or slap tear potentially. I also think he might have subluxed, but probably not fully dislocated, and that can also be associated with a labrum tear. So I would actually recommend physical therapy for this patient, okay? If you think somebody might have a subluxation, not a full dislocation, and potentially a labrum tear, unless they're, maybe I see some of the athletic trainers for the high school athletes, so unless they're a really high-level athlete, I would actually say it's safe to wait on the MRI and just try some physical therapy first and see how they do. A little bit about the labrum. Here's a picture of the glenoid labrum. It's literally like a rubber O-ring that goes around the socket here. And a slap tear is really just a type of labrum tear, okay, that's at the top here. Usually is at the front and extends a little bit posteriorly and a little bit anteriorly. And then also to point out that the long head biceps inserts at the top of the labrum as well. And we will go through the hands-on shoulder exam in a little bit, but just a refresher about the O'Brien's test, because classically it is described for slap or labrum pain. So this is Dr. Center, so you'd want the arm forward flexed to 90 degrees, elbow fully extended. You also adduct the arm slightly, and then you have the thumb down. And then And then the examiner is putting downward pressure, and you're having the patient then keep the arm there or try to raise the arm against you. And then you can also repeat with thumb up, which would be the speeds test. So this is suggestive of a labrum tear if the patient has more pain with thumb down. Okay, so a little bit more about slap tears and who gets them. So usually I think about these in a young patient, often if they had a trauma, sometimes also in, say, an overhead athlete. It's generally characterized by anterior pain, kind of deep pain and clicking. And if they fail physical therapy, which, as I said, usually we recommend physical therapy first, but if they fail physical therapy, then generally we do get an MRI arthrogram. The arthrogram makes the MRI a little more sensitive to pick up the labrum tear. Now, if it's an acute labrum or slap tear, I would argue that you don't need to get an arthrogram because you probably already have an intra-articular effusion. But if this is more of a chronic situation, often we do want to get an arthrogram. And then for surgery, for these patients, if they fail conservative treatment, then if it's, say, a type 2 slap where the labrum's just a little bit frayed, you can actually just smooth that out. That's called debridement. Or we do still once in a while repair slap tears. Back in 2007, we were repairing them all the time. And then there's a lot of newer data to support biceps tendonitis also for patients with symptomatic slap tears that are refractory to conservative treatment. And generally, we just don't consider slap tears as an etiology for shoulder pain, especially without trauma in most patients over 40, as the labrum degenerates and tends to separate from the socket naturally over that age. And then in terms of deciding between slap repair and biceps tendonitis, again, we now do slap repairs seldomly. And the reason why is that we've now found that with slap repairs that sometimes those patients do have a really hard time getting their range of motion back, especially with overhead activity and external rotation. And sometimes they actually still have some biceps and slap repair site pain. Whereas with biceps tendonitis, you're completely relieving that unhealthy labrum. And patients now with biceps tendonitis seem to not have that stiffness problem and sometimes get more reliable pain relief than with a slap repair. So this study was actually done through UCSF with some of my colleagues, but it was an imaging study showing that up to 70% of patients age greater than 50 have slap or labrum tears on an MRI. So this is an example of how we do the slap repairs. So we basically loop suture around the torn labrum, and then we use an anchor to cinch it back down to the socket. And then this is how we do biceps tendonitis. I'll switch over to this side. But normally the long head biceps is running all the way up here through the groove and then inserting on the anterior superior labrum. And we actually cut out the unhealthy section of biceps, and then we re-anchor the biceps around the groove or even a little bit inferior, which is called a sub-pec biceps tendonitis. Oops. Okay, and I'll talk a little bit about biologics and platelet-rich plasma and stem cells with respect to the shoulder. I know Dr. Luke and some of my colleagues are going to talk a little bit more about this, but platelet-rich plasma, it really is just a volume of plasma with platelet count that's greater than whole blood. There are growth factors present in the platelets, and we believe that concentration of these growth factors can be a powerful biologic treatment. And it could stimulate mesenchymal stem cell proliferation, can also be anti-nociceptive and anti-inflammatory. So to prepare the PRP, patient has a peripheral blood draw. The platelets are separated by centrifugation, and then it's ready for injection. So this is the patient's own blood. But not all PRP is the same. It was actually difficult with the literature for a while. It was like comparing apples to oranges because some formulations of PRP have more or less fibrin, more or fewer leukocytes. But we do now really believe that PRP can be helpful for rotator cuff tendinosis, tendonitis, and for partial rotator cuff tears. We think that these patients are getting some pain relief through the anti-inflammatory and pain mediators. And there's, I would say, questionable evidence that PRP is truly disease modifying, but there's also some newer evidence showing that for patients having PRP injections that ideally you want the platelet concentration to be very high, and to also use ultrasound is, I think, really standard of care these days for PRP injections. And then I'll touch a little bit on stem cells. So when stem cells first came out, say for shoulder conditions, there were a few scary stories out there. So stem cells or mesenchymal stem cells is really just a type of cell that has potential to differentiate into cartilage, bone, tendon, and muscle, may lead to regeneration of tissue, and they're present in fat and in bone marrow. But as we talked about, there are some limitations for PRP and stem cell studies. So a lot of these studies have no control group, inconsistent reporting of exact formulation of biologic treatment, again, comparing apples to oranges in the literature, inconsistent injection protocols, and overall, for a long time, there was less data on stem cells than PRP. But there are recent studies now that are standardizing the PRP formulations, and people are, including my colleague Dr. Berrigan, even going back in through the older studies and figuring out exactly what PRP concoctions were used and then trying to recompare all those results. So these were some of the early scary studies. This one was actually a New York Times article in 2018. There were 12 patients hospitalized due to infections from injected amniotic cord blood stem cells, and this is from Genentech, so a very reputable company. These patients had anywhere from 4 to 58 days of hospitalization, and then they had other unused vials which tested positive for E. coli and other fecal bacteria. So I would say, just for at least some mom and pop stem cell clinics with a lot of direct-to-consumer advertising, to just be aware. And some other issues with stem cells, they don't need FDA approval because they're really not drugs. So they're not very well regulated. They're not very good registries. And a lot of these clinics are relying on testimonials to get new patients in through the door. So looking at this study from JBJS, online direct-to-consumer advertising of stem cell therapy for musculoskeletal injury and disease. So they looked at almost 1,000 practice websites, and 96% contained at least one statement of misinformation, with a mean of about 4.5 statements of misinformation along the sites. And practices associated with, say, a physician or a podiatrist only had 22% fewer statements of misinformation. So again, you just want to be careful, but there are now better studies for BMAC and also MFAT, so adipose stem cells. And I really am starting to believe that these can be favorable at a trusted center. All right, and I'm gonna just quickly cover shoulder arthritis. So these are some risk factors for shoulder arthritis. Previous trauma, such as, say, shoulder dislocation, okay, especially if somebody's dislocated multiple times. Large rotator cuff tears, often then those patients down the road will get maltracking of the glenohumeral joint, and they will also get shoulder arthritis. You can have inflammatory arthritis, of course, such as rheumatoid arthritis, or history of infection that can be unhealthy for the cartilage, and those patients can get arthritis. And I want to just also point out that on these x-rays, so in the top one you can see it just looks like bone-on-bone shoulder arthritis, but the humeral head's not really high riding. So we actually think in this case that probably this patient does not have large supraspinatus and infraspinatus tears, but if you look at this bottom x-ray, I really do think this patient has large cuff tears at a minimum of the supraspinatus and the infraspinatus, because they're not acting like a bumper anymore in between the humeral head and the acromion. So those are probably large tears that are retracted to, say, the glenoid. So treatment for patients with shoulder arthritis: physical therapy, topical and oral medications, steroid injections. So for this, just like with frozen shoulder, usually I will, especially if they don't have a rotator cuff tear, so the glenohumeral joint is a standalone compartment, I will order those ultrasound guided with one of my colleagues. You can also consider PRP, Visco, which is off-label in the shoulder, but it is done. Also Toradol. So there definitely are a lot of other injection options for patients with shoulder arthritis. And then for surgery, that would be a total shoulder replacement or a reverse shoulder replacement or a partial shoulder replacement. And then fewer and fewer partial shoulder replacements are being done these days. So this is a picture of a standard total shoulder replacement. These can be done if the rotator cuff is overall intact or very repairable. So you do replace the ball and the socket side. And it's variable, the survival, but overall very good. And this one study showed about 95% 10-year survival. And then there's also reverse shoulder replacement. Those have been done in the US now for about 20 years. And these are for arthritis with rotator cuff tears or large rotator cuff tears, even without very much arthritis, but these tears just are not repairable. And these have about also a 94, 95% 10-year survival. Thank you very much. And then these are my 2 kids that were evacuated yesterday. They're elementary school. I live in Pacifica, about 20 minutes south of here, right on the coast. And their elementary school is literally on Highway 1 across the street from the ocean. But they're fine. So thank you for listening. And we'll move on to the physical exam. I'll actually take this off. And yeah, Katie, just let me know where you think it's good to stand for the screen, right? Stand over here?
Yeah.
Oh, stand over here?
Yeah, left side.
Okay. Okay, great. All right, everybody. And this is Alyssa. She's one of our trainers. You're also going to be leading the yoga session today at lunchtime. Okay. Yeah. So I'm just going to go through my essential shoulder exam. Okay. So first, I do like to just do inspection, all right? So I look at somebody from the front. So for example, if she had a shoulder separation or acute AC injury, you might see that her AC joint is asymmetric. And then I also do like to just look at how the shoulder blades move, okay, and just check for winging. So actually, let's have you stand up, Alyssa, and why don't you face the UCSF sign over there? And then let's just have you keep your elbows straight and just bring your arms all the way up overhead. Good, and then bring them back down. Okay, and then do the same thing, but bring them all the way up to the side and all the way overhead. Great, and then bring them back down. Okay, good. And then you can have a seat here again. Yeah, so I at least would do that on my new patients. And then I do like then for the exam to have them ideally have their shirt off or have a woman in a gown or tank top or sports bra, because I do think that is something that you don't want to miss. You also can check for atrophy. So there are certain conditions like say spinoglenoid notch cyst, where you actually can have visible muscle atrophy over the posterior shoulder. So I would say that's my inspection exam. And then for palpation, I'll cover a couple highlights here. So you definitely want to always push on the AC joint, okay, to see if that's a source of pain for a new patient with or without trauma. A lot of patients will come in with, say, an X-ray or an MRI report that says that they have AC arthritis or AC degenerative changes. This is very common as even an incidental finding in people, say, over 40 or 50. So you do want to try to correlate that with any tenderness. So for the AC joint, it's going to be this bump. The bump is actually the distal clavicle. So the true AC joint is just lateral to that. So I basically push over the distal clavicle and a little bit lateral. And then I also push over the front of the shoulder, around the labrum, and also the long head biceps. Okay, and then you can also palpate laterally. If somebody has, say, a painful supraspinatus or infraspinatus tear, they'll often be tender laterally just below the acromion. Okay, and then next, I like to check range of motion. Okay, so I'll show you the different planes for range of motion. So Alyssa, let me have you tuck your elbows in like that. Keep your elbows at the side and then rotate your arms out. Okay, so that would be external rotation. Normal is about 70 degrees. And then we'll go to internal rotation. There are a couple of different ways you can do this, but the way I usually do it is have them bring their arm up their back like this. Good. And yeah, she's very flexible, very flexible. Maybe even better maybe than T7. Yeah, so she's very flexible, but on average I would say it's about T10, T7. So that would be internal rotation. And then I like to do forward flexion. So Alyssa, you can just bring your arms all the way up overhead. Good. Generally you want about 180 degrees. You can bring them back down. And then how about abduction? So you can bring your arm all the way up to the side. Good. Okay, and then you also could check extension, but generally that's just not as necessary. Okay, so then we get to strength testing. So I always just start with internal and external rotation testing because her arm's just at the side anyway. So I'll say tuck your elbows in and then push out against me really hard. Good. Okay, and then push in against me. Good. Okay. So that's internal and external rotation. Internal rotation in that position, there are a lot of different muscle tendon units that provide that function. So I would say that that's not that specific. But external rotation, you definitely are testing the infraspinatus and teres minor, okay? And then we'll go to the empty can test, which is also like abduction strength testing. So I'll have you put your arms like this. Good. And keep them there really hard. Don't let me push them down. Good. Okay. So usually you have her arm abducted between, say, 45 to 90 degrees. And then the key is you want to have her forward about 30 degrees, okay? Because you want her in the scapular plane. Traditionally, this empty can test is taught thumb down. There are some studies now to where we think it actually doesn't really matter for supraspinatus strength testing, but traditionally we teach it thumb down. So we call it the empty can test, but it's also the supraspinatus strength testing test. And then I like to check forward flexion strength testing. So I'm gonna have you come all the way up front like that. So she's forward flexed to about 90 degrees, a little bit adducted, thumbs down. So this is forward flexion strength testing, but this is also the O'Brien's test, okay, that Dr. Center demoed. So keep your arms there really hard, don't let me push them down. Okay, good. So she has good strength there, 5 out of 5, and she did not have pain. So I would say that she has a negative O'Brien's. And while I'm there, I say, okay, Alyssa, do the same thing for me, arms out front like this, but palms up. Okay, so this is gonna be the speeds test. Keep them there really hard, don't let me push them down. Good. Okay, so that's the speeds test. You can relax. And so if that was positive for pain, then classically you would think about a biceps tendon etiology of her pain, like biceps tendon tearing, biceps tendonitis, okay? Then we'll move on to subscap testing. So I like to do the belly press. Let's have you go like this, okay. And then I like to put you have to put your hands between, the examiner has to put their hands between her hands and her belly. So I'm gonna put my hands here and then just push in towards your belly against me. Good, okay. And that tested strong on both sides, so that would be 5 out of 5 or a negative belly press. Belly press actually slightly tests the upper portion of the subscapularis more than the lower. And then I like to do lift off. So let's have you stand up and actually turn facing the UCSF logo again. And then I'm gonna have you put your hands like this on your bottom, facing away with the palm, good. Okay. And then I'm just gonna have you lift your arms away from your bottom like that. Good, okay. So she's able to do the lift off, all right? Technically, lift off is not graded by, say, 3, 4, 5, okay? It's just, are they able to do it or are they not able to do it? The other little pitfall with the lift-off test, and I was actually just reading this in a Subscap article the other day, is when you do it, you can even tell the patient, hey, keep your elbows at about 90 degrees. Because sometimes you'll say, okay, do the lift-off test. Can you lift your arms off? And they go like this. So they're literally just moving their elbows. They're not really elevating their arms off the bottom posteriorly, okay? And then also in this article, it was saying that if somebody cannot do the lift off, okay, again, it's not graded with strength, that generally means they have at least a 75% tear in the subscapularis, okay? And then the other test for subscap is the lift off. So we'll say it's her right shoulder that's affected. So let's have you go like this for me, elbow a little bit higher, good. And then keep your arm there really hard, don't let me pull it up, okay? Good, okay. So that would be a negative, bear hug. That's the bear hug test. So that would be a negative bear hug test, okay? And belly press and bear hug do tend to test the upper portion of subscap a little more than the lower. So that would be strength testing, and then we'll move on to the impingement signs, okay? So we'll pretend that it's her right shoulder. So the impingement signs, Neers and Hawkins, they are both passive. So for this part of the exam, I just say, okay, just really relax, let me do the work. So let's do the Hawkins first. So I usually hold the wrist with one hand and then the elbow with the other. I bring the arm up to about 90 degrees of forward flexion with the elbow flexed about 90 degrees. And then what you want to do is internally rotate passively. And then if it's positive, she'll get pain at the end range here. Does that hurt at the end? Not really. Okay, so that would be a negative Hawkins. And then let me show you Neers. So we remember like near to the ear, and Neers is passive. So really relax your arm. And I like to have one hand around the elbow, and then I just bring it up. And do you hurt up there at all? No, okay. Okay, and Katie, how much time do we have? Because we're still good? Okay, and then just another thing that I wanted to point out on motion, okay, is, and I touched on this in my talk, but you always want to think about passive versus active, okay? So again, we talked about if somebody is stiff in multiple planes, especially with rotation, active and passive, then you need to think about frozen shoulder or glenohumeral arthritis, okay? Sometimes though, somebody's passive range of motion is great, but their active range of motion is poor, okay? So say Alyssa has an acute full supraspinatus, infraspinatus tear, all right? So on exam, so let's pretend, we'll pretend that that's the case. So on exam, she might not be able to lift her arm very high on her own or externally rotate it very far on its own, right? But if I do it passively, so I say, okay, relax, this might hurt a little bit, but try to relax, then I can actually get really good motion, okay? Then I know she doesn't have frozen shoulder or arthritis. And if I can bring her all the way up, but she can't lift it there, then I am worried that she might have a large, acute, full thickness tear, and that's somebody where I'd want to get an MRI. Oh, and then let me just cover one more essential test. So there's another one. It's called the crossbody or cross arm test. It's also called the scarf test, and I'll just highlight that it is described for AC pain. So say an inflamed osteolytic AC joint, like a weightlifter's shoulder, or also for symptomatic, say AC arthritis. So with that, I just have her bring her arm across the chest. This really could be active or passive. I usually do it passive, and I'll just sort of bring the arm across like that. And then if she has pain at the AC joint, it's considered positive, okay? If she had, symptomatic labrum tear, she might hurt anteriorly, and then that would actually be negative for AC joint pain. And then there's also a test described called the resisted crossbody test. So keep your arm there, Alyssa, and then push back against me. Okay, yeah, so if you're really suspecting AC pain, you could do the scarf test, which is more passive, but also have them push out against you. And if both of those are positive for pain at the AC joint and they're tender at the AC joint, then you're pretty sure that the AC joint is at least part of what's causing their shoulder pain. Should we pause for just questions? Because there are a lot of other physical exam tests that I could show, but I was just showing the essential, and I didn't know if anybody had some questions. I'm happy to take questions. Yes, Pinder.
Can you speak to specific tendonitis and how you determine that without a diagnostic test, versus just regular tendonitis, because they're different?
Sure. Yeah, so calcific tendonitis, it is fairly idiopathic. Okay, so we really don't know why certain people get it or even get it in both shoulders or are recurrent and other people don't. Classically, those patients present with just severe acute pain. I mean, to where these people even go to the urgent care. They can barely move the arm initially. It really wakes them up at night. It's one of the most painful types of tendonitis. I would say you do need an x-ray. So with UCSF, we do have x-ray in all of our clinics. So if somebody comes in for new acute shoulder pain and they don't have an x-ray, I really do encourage them to get that. And that is one reason why I explain why, that look, you might have calcific tendonitis, and the only way to know is to get an x-ray. So I would say I would encourage patients to get an x-ray or have them come to us for an x-ray if you think that it might be acute, severe onset calcific tendonitis. Now, interestingly, with calcific tendonitis, the calcium's within the cuff. It's like gritty toothpaste, so they usually don't have a rotator cuff tear. And then for treatment, it is sometimes a little bit different. So you could do just a subacromial cortisone shot, but often with these patients, especially if they have a medium to large size deposit, I will send them, say, to Dr. Hadamiya with ultrasound, and they can actually do something called barbotage, where they can use a little larger needle with some irrigation and basically just try to suck and flush that gritty toothpaste out. And then often they'll put a little cortisone in there too.
Is there a size limit to how big that can be in order for the barbotage to be done? Like if it's really big, do you know? Or is that
Nick, is there an exact? I mean, I've definitely sent some to my colleagues where it was, say, 1 by 2 centimeters, but it's just rare that the deposits are that large. Yeah, Nick, is there a size where you wouldn't do it?
It can be a lot longer to sit there and try to barbotage the whole thing, and you can repeat the barbotage procedure. So sometimes I'll usually follow up with them at 3-month intervals, and then re-ultrasound, they'll look and measure and see if there's any interval change. And if they're amenable to it, you can consider repeating it. There's another proprietary procedure that you can do called 10X, which is using an ultrasound guided needle to help break it up. That's a little bit quicker. That my colleague Dr. Garrett as well. So there's a lot of other options besides the more
Yeah, and we do once in a while do surgery for those patients too, if it's just totally refractory. But when we do those, we always consent the patient actually for rotator cuff repair, because sometimes once we've mechanically dug it out with a shaver and a curette, it leaves like a hole in the rotator cuff that you have to reinforce. Yes?
When it comes to post-operative arthrofibrosis for like a frozen shoulder after surgery, do you have a time frame at which you would wait, and is there a time frame at which you would no longer do it?
Oh, sure. So are you talking about
Manipulation under anesthesia.
Oh, sure. So surgery and manipulation for frozen shoulder. Are you talking about when would I seriously consider doing it?
Yeah.
Sure. Yeah, again, very rare. I'd say maybe once a year I'm doing surgery for frozen shoulder, and I do shoulder surgery every week. For me personally, I would say usually they'd have to have had symptoms for at least 6 months. Ideally for a year. I really would encourage them to wait it out for a full year, and they've had to fail conservative treatment, like at least a one-time glenohumeral injection, anti-inflammatories, physical therapy, diabetic management, and then usually they'd also have to fail one of these other procedures like a suprascapular nerve block or hydrodilation. But if it's been 6 to 12 months or more and they've failed those and they're just very, very miserable, then absolutely I would consider it. And then what we actually do, it's like a combination of arthroscopic surgery and what we call lysis of adhesions, where we have a little cautery wand that cuts safely, and we make like on purpose rents in the capsule. So we make a little rent or two, and then we gently manipulate, and make a little rent or two, and then gently manipulate. So it's a combination of a capsular release and manipulation. And then a lot of times with those patients, I send them home even with, say, a suprascapular nerve block catheter. And I always make sure they have good physical therapy set up right away after, because you just don't want them to refreeze. You need to make sure you're very hands-on and they have really good pain control after. Yes?
With a patient that's presenting with a subluxation or a dislocation, how do you guide the primary care physician in terms of X-ray, MRI, referral?
Sure. So, and then by that, I'll repeat the question, but are you talking about, say, a first-time kind of traumatic?
Yeah, first time you have.
Okay, so the question is, say for a primary care physician, if you have a patient that comes into your clinic from, say, either a sports injury or a fall where you think that they might have subluxed or dislocated their shoulder. So first of all, yeah, I would always at least get an X-ray, okay, because you do want to just make sure that it is in place. Sometimes on an X-ray, especially if you get an axillary view, which you should always get in an instability case, that's like a bird's eye view. Sometimes you'll actually see a bony Bankart, like a little chip off the front of the socket, and that would mean they probably fully dislocated, or a Hill-Sachs, which is a little dent in the back of the ball, which that is also an indication that they dislocated and not just subluxed. So I would definitely get an X-ray, which would include an axillary view, so minimum of 3 views. I would do a physical exam. If they're young, but say not a high-level in-season athlete, I actually think then if their physical exam is pretty reassuring, that you could just start with physical therapy for that patient and not get an MRI. If they're older, I would say over 50 or 60, and they had a first-time traumatic, you think maybe dislocation, and on exam they're weak, then I would say you actually need to get an MRI or refer them to us, okay? So the issue is younger people who fully dislocate, like say under 30, their issue is they keep redislocating, okay? So they often need stabilization surgery in the end. People over 50 or 60 who fully dislocate, they often will fully tear their cuff. And we don't want to miss that, okay? They probably won't keep redislocating, but they might have a full thickness cuff tear. So those are people that I would think about imaging. And if you're ever on the fence, then you're welcome to just, send them to us, and then we can figure out, if we think that they need an MRI or not. But I would definitely order physical therapy. Mm-hmm.
Elly, let's take a few of the questions from the app, because there was a good number of good questions in the app. So the first one was, in place of an MRI, which will take about 18 months to get, not wrong, would you recommend an ultrasound for rotator cuff disease?
Sure, no, good question. I would say yes. I would say yes. The options, you could get, say, a CT arthrogram, and I've seen that done, but I just don't think that you could see the cuff tissue very well. I mean, you could get a CT arthrogram, and if you had leakage, that would show you probably have, say, a full thickness tear, but also that is just a lot of radiation pain for the patient with the arthrogram and resources. So yes, I do think ultrasound is a good option. I do have some patients in my practice where they just cannot get an MRI. I just had one the other day. He had some really complicated, like sleep apnea implant in his neck, or some people have cardiac implants where no matter what, they just cannot get an MRI. So then I do think ultrasound is good. For me, I prefer MRI, and the reason is that I read MRI also, okay? So for me, especially if I'm doing surgery planning, I like to personally look at it. But yes, I do think ultrasound is a great alternative, very safe and readily available, even in my group with our partners.
Great. All right. This one came through a couple different places. You started throwing people off. What is SIRVA?
Oh, sure. SIRVA is a systemic inflammatory response to vaccine administration. I believe that's the exact mnemonic. Let's see. So SIRVA, it's actually been out, this phenomenon has been out for years, but I would say during the pandemic, it got a lot more press, and we were seeing a lot more cases. So what it is it's an inflammatory shoulder response to some type of vaccine injections, so even the flu, okay? But there were a lot of case reports early on with the COVID vaccines where sometimes people for months, they would just get severe shoulder pain and inflammation as a result. And originally we thought that it was perhaps because the vaccines were basically not put into the right place. So instead of being put in the deltoid muscle, they were actually put into the subacromial bursa. But they have now done some studies that show that even if they're put in the correct place, say in the deltoid muscle, that some people will just get a localized inflammatory reaction, say in the bursa, so bursitis, that can last for months, and also then cause frozen shoulder, because then the glenohumeral joint can also become inflamed and the patients are in pain, so they're not moving their shoulder properly. So that's why they think during the pandemic, it could be one reason why there was an increase in frozen shoulder cases.
All right. How does management of rotator cuff disease differ in pediatric patients?
Ooh, pediatric patients. So pediatric patients, I would just say rotator cuff disease is very rare. I mean, Danny, I know you're a physical therapist. I mean, very rare. I think in terms of rotator cuff surgery, I did do it on an 18-year-old once. I still remember she was, I think, Academy of Art and was a volleyball player and dove and landed on an outstretched arm and acutely tore her supraspinatus. But just rotator cuff disease, even full or partial tears, are very rare in younger patients. They do sometimes get, say, the partial mild articular sided tears, like in a throwing athlete from, say, internal impingement and internal rotation tightness, which is a whole different talk, like thrower's shoulder. Some of those people will get some mild undersurface rotator cuff tearing, but just in general, I would say we don't really see a lot of rotator cuff disease in the pediatric population. Nick, would you say you agree? I know Nick has a family medicine background.
Yeah, that's correct. I would say it's really uncommon. You can see traumatic tears, but less common than adults, and none of the degenerative.
Yeah, I mean, we have a sports medicine center for young athletes, and Nina's on it as well. And I don't think I've ever seen a kid under the age of maybe 16 with a rotator cuff issue. We're more worried about physis injuries and growth plate inflammation when we're seeing shoulder injuries. All right. For injections to the rotator cuff, do you recommend PRP or injections with hyaluronic acid?
Oh, sure. To the rotator cuff for, say tendonitis, tendinosis, or partial tears, I don't think there's good data for visco for those cases. I would then recommend PRP. Visco is more studied for intra-articular administration, say classically for knee arthritis intra-articularly, that's what it's FDA approved for. So I would say most of the time if a patient's having visco into the shoulder, it's into the glenohumeral joint.
All right. This is more of an acute management question. Can you give an exam suggestion or any exam suggestions for 24 to 48 hours post an injury, as almost all have restricted range of motion and pain with movement? It can be hard at that point to distinguish shoulders that are okay to wait and watch with PT versus the need for ortho.
Sure. Okay. Yeah. So say somebody fell or had a sports injury and their shoulder's just really, really sore and therefore stiff, and you're seeing them within a day or two. So how do you kind of differentiate like what might be going on, and do you need, say, an MRI? That is a really good question. So first of all, I think it is important to have an X-ray, okay? Because again, we want to make sure that there's not a sign that they dislocated or that they're still dislocated, or sometimes people will fall and they actually have like a fracture of their humeral head or their glenoid, okay? So yeah, you want to make sure that you're not missing that. So make sure that you have an X-ray. And then I would just say that I just do as much of a gentle exam as I can. Usually people tolerate pretty well doing some strength testing if the arm and elbow elbows are close to the side. So actually I'll show you with Alyssa here. So say her right shoulder was just like severely painful. She's like, oh, I just can't move it much. It hurts so bad. But say her x-ray was negative, okay? So I would just say, okay, well, I'll try to be gentle. Just do as much as you can. Tuck your elbows in like that. And can you push out against me just a little bit? And can you push in against me just a little bit? So usually they'll tolerate some gentle isometrics with the arm just at the side, and then I'll try to do a little bit of, say, an abduction or forward flexion position. So can you bring your arms just a little? Okay, I know it'll hurt, but try to keep it there just for a minute. Okay, good. And then I will try to do some gentle passive motion also. Yeah, so if doing, say, external rotation and one of those elevated isometric gentle strength tests, if they're really, really weak, then it would make me worried that they might have an acute traumatic rotator cuff tear. So then I would be more likely to get an MRI. But yeah, sometimes you are really limited. I mean, I don't do impingement signs on those patients. Sometimes they can't tolerate Speeds, O'Brien's, or say the bear hug. So you just have to do a limited exam. Yes, we have a question.
In that case, I often just bring them back in like 10 days, 2 weeks, and I understand that if you have like a full tear, that it's not an urgent surgery.
Yes, good point. So another strategy would be, that is what I would do, say, for the initial exam. But if you don't think they have an acute, large, full thickness tear, and the x-ray is negative, so you know they're not currently dislocated, you don't think that they dislocated, then yes, it is actually safe to just let them cool off, take anti-inflammatories, do some gentle therapy. We actually have our athletic trainers in clinic basically give them an acute shoulder program just to jumpstart some range of motion and isometric strengthening. And then I totally agree. You could then have them come back in, say, 2 weeks or so, and then try to get a better, more accurate exam. And if that exam's really reassuring, then I would say just have them continue with physical therapy. But if it's not, and they're still really weak and have limited active motion, then I would think about getting an MRI at that time.
All right, that's unfortunately all I have time for Dr. LaRoque, but can we all give a round of applause for Dr. LaRoque?